I'll open us up with karakia. Tūtawa mai I runga, tūtawa mai I raro, tūtawa mai I waho, tūtawa mai I roto, ki tau ai te mauri tū, te mauri ora ki te katoa haumi e hui hai ki. It's beautiful to have you all here today to talk about a topic that's evolving, is getting, I guess, changing every day, and there's new things that are coming out and around it. So we're looking and we're talking about today the technologies that support our patients and our whānau with long-term conditions in general practice or in primary care. How do we support them out in the communities? And as we have technology, I asked ChatGPT about 5 minutes ago how many New Zealanders in New Zealand have a long-term condition, and it's around 1 in 4 apparently, which I think is probably quite accurate. So this is a majority, like this is a very big cohort of people within our community who are suffering from a long-term condition and need support and tools and resources to help them manage that efficiently, effectively, and hopefully improve their outcomes by doing so. So today we're going to hear from some people in our panel. So we've got John here, he's here from Te Whatu Ora. We've got Amy and Fred here from Auckland University, and we're really looking forward to hearing from you guys what you're working on, what's happening in your sector, and how you see this evolving and changing over time. There is some questions that I've got here that I will ask, but I do welcome you to use the Q&A function on the webinar and ask away, and I'll moderate those and ask the panel those questions as we go. So do kind of jump in there. But let's just do a little bit of a round of intros. We'll go Amy, John, and then to you, Fred, a little bit about who you are and why you're interested in this topic.
Kia ora koutou katoa. Lovely to meet everyone online. I'm really good to see I've got 24 people online and increasing. So this is really exciting to see so many people interested in digital health. As Jess mentioned, I'm from the University of Auckland School of Pharmacy. I'm an associate professor here, and my main research interest is around digital health interventions, and particularly in the respiratory space. I do also work with my close collaborator, Fred, who's also one of the speakers around the overlap with long-term conditions and mental health as well. So my particular interests, I'm a clinical pharmacist by training, but I'm very interested around prevention rather than cure. So what can we do to keep people well, keep people living well, and how digital technologies that we have could be positioned to help keep people well and away from having sickness. So that's what we'd hope to discuss. So lovely to meet you all.
Nā mihi ki a koe, Jess, ko John Henry toko ingoa no Ngāti Roa Nui Ahau. I am the GM for New Technology and Innovation at Te Whatu Ora and Data and Digital. My team, our job, been around for a wee while, and we moved as part of Data and Digital out of the Ministry of Health and into Te Whatu Ora. We have kind of 4 areas of focus. So the first area is an innovation funnel and innovation fund. So how do we support kind of good innovation to happen? The second one is the innovation studios we've been working on, and if you know anything about digital health, you might have seen some stuff come through in the eHealth news about that. We're working on virtual care, which is something you all might be quite interested in this conversation, and then we're a part of a group looking at a tech accelerator. So what is it that we could do faster with technology? And happy to talk about a few of those ideas and efforts that we've got underway at the moment. Kia ora.
Hi all, I'm Fred Sundram. Thanks Ni and Jess for inviting me to take part in this forum, and thanks Amy for the introduction as well to Collaborative Aotearoa. So great to be here today and great to see so many people attending. By way of introduction, I'm Fred. I'm based at the University of Auckland as an associate professor, and I'm a deputy head of department as well at psychological medicine. I work 2 days a week clinically in liaison psychiatry in Waitemata, and that looks at the overlap between mental and physical health. And how I got interested in this digital space is, I think one of the criticisms in psychiatry is the lack of potential objective ways of diagnosing somebody with whether it's depression or bipolar or any other mental health condition. And technology has been rapidly evolving the last couple of years. most people have heard about ChatGPT. Artificial intelligence was the word of the year or words of the year for 2023. So it's a really fantastic, really interesting space. And I think psychiatry has a lot to gain potentially from actually looking at the blend between mental health and technology, potentially artificial intelligence. So I think it's a really exciting space.
Yeah, kia ora, Brett. I think we all agree with you that it is a super exciting space and it's got such potential to really shift the dial on how we're managing patients with long-term conditions. So to kind of kick us off, Amy, do you want to take us through your little presentation and your topic? I think you're going to be talking to us about uncovering and exploring efficient methods for self-monitoring and remote tracking of asthma.
Yes, great. Thank you. I think Nee's got my slides. Great. Thanks very much, Nee. Right, so as I said, I'm talking about digital technologies and remote asthma monitoring, and asthma in particular. It's very, very dear to my heart. A, because I live with asthma myself. B, a lot of whānau who also have asthma, and importantly for me of concern is even though the prevalence of asthma is pretty stable, we said around 1 in 7 children and 1 in 8 adults have asthma in New Zealand, we still remain top of the leaderboard in terms of being one of the countries with the highest rates of asthma. And what our data also showed is concerningly those rates in terms of asthma attacks, so asthma control, is increasing, and in the last 10 years we have seen a third increase in the number of asthma attacks that our population have been seeing. So whilst the number of people taking into account population growth is fairly stable in terms of percentage, in terms of control, people are getting sicker, and so people who are living with asthma have more symptoms and more hospitalizations and more attacks. So because of what we were seeing, we really wanted to focus on attacks, which is much the focus of my research. In particular, there is this particular part in a timeline of attack. People think they suddenly go from well to having an attack, but actually there's this onset phase, which is a progressive phase of variable recognition of symptoms. So some people are very much aware of it and some people less so, but because it can range from minutes to week or potentially weeks, this onset phase, there is this particular opportunity that we could use with digital technology to see if we could detect those early changes and potentially be able to reverse the exacerbation or even abort the attack completely. And so this is where digital technology comes in. I just wanted to highlight some of the stats. And in particular, I was particularly excited to see that year on year, one of the biggest pieces of technology that has the greatest growth is access to smartwatches and smart wristbands. So roughly about a third of the world owns smartwatches or have access to smartwatches or smart wristbands, and the rates in New Zealand are pretty similar. But as you can see, as one of the highest growing percentage use of technologies is the smartwatch, with around a year-on-year change of 9%. As you can see, with smartphones, we're pretty much maxed out in capacity, so the year-on-year change isn't that great. But we think the growth of access to smartwatches and smart wearables will be increasing over the next couple of years. And this is exciting because the use of these wearables often provide insights that can't be accessible with traditional care. So we can think back to our patients that we see, and we can only see it at one point in time, and very much the consultation is a cross-sectional process, and we try and gather as much history as we can, but obviously that comes with its own limitations. The beauty of having wearable technology and using wearable sensors, so things like having a microphone, for example, on your smartwatch, on your smartphone, or activity tracker on your smartwatch, is that you can collect data pretty much 24/7, and it allows us to generate alerts and forecasts and ultimately actionable insights, and basically allow health providers to intervene earlier, but also provides patients and allows them to be empowered to actually see what's happening in their health and their bodies in ways that they weren't able to before. And so in terms of attacks, and this is how we contextualize attack risk. And so we really think there is this key opportunity that technology can be used to intervene in the days and weeks before an attack actually happens. So we then delve into what's happening into asthma, and we look into the airways. What we're trying to do is see, can we capture those changes using wearable technology? And this is what we have using an AMRF and HRC funded study, the digital asthma study, DigiPredict. And what we're doing at the moment is recruiting 300 people with asthma around New Zealand, so people living with asthma and their whānau, and we're trying to give them easily accessible technology, so a smart inhaler, smartwatch, and then some measures that they can collect on a smartphone app. And we're trying to use AI and machine learning, as Fred mentioned. It's very topical. We're trying to use artificial intelligence in terms of intelligent ways of monitoring all this granular data, combining it with Ministry of Health data sets and environmental data to basically generate a risk score, which allows people to get an idea of their asthma status at a glance and provide, as we said, actionable text messages or other notifications, as well as information for the patient and the healthcare team, hopefully to reverse some of the trends that we're seeing with asthma attacks. So really, this is the summary of kind of what we're doing and where are we aiming for. The study started last year, and we've got about 56 people so far through the study. So really, as well, those on the call with your networks, would love to hear from any patients that you think might be interested in the study. So we are recruiting anyone who's 12 and over, and they'd be given this technology. They get the smartwatch to keep at the end of the study, and they also get the bonus of being able to see insights and using some of this cutting-edge technology for 6 months during the study. So he said, at any point, just feel free to get in touch. I know we'll have the rest of this webinar to have a good kōrero with the rest of the panel. We would love to hear from any of you as well who's interested. Kia ora. Thank you. Ngā mihi nui.
Kia ora, Amy. That's awesome. It's so exciting to see, and I think the results of that study are going to be quite compelling as well. So, yes, if in any way we can help, we will absolutely support that. We're going to go to you, John, to talk to us about some of those exciting projects that you've got going on in your role at Te Whatuora. Kia ora.
Kia ora, Jess. So we've got a couple of projects that I want to talk about. First one is some work called Pikitiora. It's the name of the app that we've been using or building as a platform and then using, and it's kind of come out of a number of kind of studies done internationally and work that's been done in this country around remote monitoring. And there's a few things that kind of stick out for me in terms of what would make this work better and what would make this work not work is probably a good way to describe it. First kind of example I give is kind of that multi-morbidity one. So while we might start simply and say, hey, here's a care plan for heart failure, or here's a care plan for COPD, I'm sure a lot of people know that these sort of things don't come in single occurrences. So, you know, the person with COPD or asthma possibly also has diabetes or heart disease or something else going on. And, you know, the experience I can imagine is, oh, well, now you need to wear 2 watches because the watch for COPD doesn't talk to the watch from heart failure. And so you need 2 apps and 2 phones to go with that. So that kind of, you know, if I was to describe a bad experience for a consumer, that feels like one. Another one is kind of the transition between kind of being well and being unwell and then back to being well again. So, you know, the reality is, you guys in primary care will know this, most people don't spend life sick. Well, they certainly don't think of themselves in that way. Hey, I might have heart failure, but I'm normally okay. And so the last thing the last thing they want is, oh, yep, so I've got a watch and I've got some scales for my heart failure, and suddenly I'm not feeling very well. And, you know, what turns up on my doorstep the next morning is a set of scales, a new watch and a new phone with a new app because I'm sick, and the expectation that I learn how to use it while I'm sick and then have to switch back again once I'm well again. And then you've kind of got that question about how that combines with the thought that I'm already wearing 2 watches because I've got 2 things wrong with me, and how does that interact? So you can start to see complexity for a consumer is a real big problem here. When we talk to counties Manukau, went around the hospital and said, hey guys, have you got any idea of, services you currently offer in person where remote monitoring might help? And we stopped counting at 60 different use cases. So you can see that this isn't going to be a small thing, it's a big thing. And there's potentially lots of overlap between some of these things. So knowing somebody's blood pressure is important in a lot of different specialties, as is oxygen saturations, as is heart rate or heart rate variability, because they're kind of indicators of lots of different pathologies. So in that, what we've been working on is kind of a platform that we can make available for different use cases. So starting from where does the data get stored? Data gets stored by Te Whatu Ora in AWS, so Amazon Web Services, using tool sets that we built for COVID. So all of you will be familiar with COVID care plans. We're using the same storage layer as we used for COVID care plans. And the method we're storing it in is using something called FHIR, which is interoperable, basically. So we're storing it as interoperable data. We're not adding interoperability in later. We've then built a mobile application for the consumers that lets them log in with their My Health account. So the same My Health account we're using for My Health Record and we used for the COVID vaccination program. Same login. So if you've already got a login for that, you can use the login for this. We then have connected on the phone to something on Android called Google Health Connect. So if you're an Android user, you might have heard of this. It's kind of the Android version for all of those iOS people out there of the Health app, where we can take the data that any of the devices that are connected to your phone can put into that shared space. So doesn't matter which watch you wear, doesn't matter what you plug in to your phone. If your phone's sharing it with, or if the apps and the devices are sharing it with your phone, we can then pick that up. What we've then added to that are a couple of other features. So I've just got off a call talking about proms and prems. What we've built into that mobile application is native notifications for the app. So you get a notification every morning if you're on our heart failure care plan that we're working on, to ask you what your symptoms are for the day. So you get a at about 8:45 in the morning, and that then gives you the ability to hit one button and say, I've got no symptoms today, or I've got these 3 symptoms. We can make new forms ourselves really easily and really quickly, which is great. But kind of question being, what are the questions we want to ask, and how do we make that as efficient as possible, and what does it mean if people aren't filling it out? Another feature we've just added is a group chat. So we figure there are a lot of services online like Facebook, or the NHS ran something called Patients Like Me, which is like an online user forum so people can talk about the fact that they've all got heart failure and how do they manage their heart failure, and get some camaraderie and some social engagement through that. So we've just built that into the app as well. But something else that's kind of come up in our conversations is, wearables don't suit everybody. So we've got a guy that's a forestry worker. He's got really big forearms because obviously he swings an axe or uses a chainsaw all day, and we can't get a watch strap big enough for him to wear. We've got another user that has tattoos on his arm, so can't actually use a smart device for that. So we've built in a third-party SDK for using the front-facing camera to measure some of the similar kind of physiological parameters. Happy to talk in more detail with people about that, but works in the same way as a finger-based pulse oximeter, whereby rather than shooting red light at your finger and getting the reflectance values, it uses the sunshine that reflects off your face and then divides it into different channels using the camera on the front of your phone. So same but different. That tool set is then all of that's collecting data against an NHI number using My Health account, and it's stored in our services like I described before. We're working currently with BPAC to surface that in general practice. And there's a paradigm shift here too. So normally in primary care, you put in an NHI number, or you put in someone's name and bring up their records and then find out what's going on with them. And you might do some queries out of MedTech in order to create a list of people. We've kind of taken that a bit further to say, hey, you should have a table of all the people you're monitoring like this. So you can have a view which has, let's say the 100 people with heart failure in your practice that you're monitoring, and you should be able to sort and filter that table by who's given us data in the last 2 weeks, who's got numbers that aren't what they normally are, who's got symptoms today when they didn't have symptoms yesterday. So that means you can find the people that you care about giving a call or following up with first, rather than having to, I need to search for the first person in their NHI, bring up their records and have a look at the data and then close them down and then bring up the next person. So kind of that paradigm of, hey, I can look at this cohort, I can decide from that cohort really quickly who I want to follow up with, and then I can go into their records and look at them in detail. So that sort of model is really interesting. The next kind of thing we're really interested in is probably the education and skills space. So we've got 2 active conversations in this space, which are quite interesting. The first one is answering questions about medication. Without fail, every person we've talked to on our trial so far complains about no one ever explaining to them what furosemide does, and the fact that they should be taking it in the morning. And so we're currently working through what it would look like to have something like ChatGPT rewrite our medicines information based on your personal preferences. So if I explain what that means, some of you might have seen me talk about this at HINS last year. We want to give a consumer the ability to make the content as short or as long as they want. So give them a slider on the screen, make it as short as I can, make it as long as I can, so more explanation or less, and then change the complexity. So make it as easy to understand or as complicated as you want. It's interesting, I was on the Heart Foundation website learning about heart failure, and about 3/4 down the page it started talking about fibers of Purkinje, and as a general consumer, I'm how relevant fibers of Purkinje are to a consumer, but these are the types of things we try to tell people about in regards to their heart failure, and then forget to tell them about the fact that furosemide makes you pee. The third kind of contextual element we've got in terms of how we want to change the content for consumers is the tone. So depending on kind of how you tell the story about some of this, depends on how receptive people are to it. So we're talking about an informal or fun tone versus a very serious tone, and you choose that as a consumer. And one of the designers was then talking about, could we change it to be in the voice of? So some of you'll be familiar with the scandal on the internet at the moment about Scarlett Johansson and ChatGPT using her voice. Question about whether you could put it in the voice of somebody. So, hey, put it in the voice of Sir Ashley Bloomfield telling me about my heart failure, or put it in the voice of Sir David Attenborough telling me, of Taika Waititi telling me about my heart failure. Now, obviously, these things are much more complicated, and as ChatGPT found out, you probably want to talk to those people before you start pretending to be them. But these are the types of things that we're looking to test at the moment: is can we give a personal voice from the community that people trust, who will give them the information that we need to give them in the voice that means they'll either understand it or trust it, or both, hopefully, from that. So that's kind of project number 1. We're working with Whakawhiti Ōtapai in the far north for that, Ngāti Porou-Oranga on the east coast, and we're working out in Wharekauti on Chatham Islands. So we picked the hardest places in order to try and test this stuff. So that's project 1. The other project we're working on, some of you all know about NABLA and probably are also using it. You might have also heard of other products like Lyrebird or Health Heidi from Australia. We're working in this space at the moment, currently going through security review in order to do some product testing. And then we're interested in doing some formal evaluation of it. Obviously, for those of you that don't know what this is listening to the clinical conversation, so the conversation between the patient and the clinician, and then taking that, turning that into a text kind of conversation, so a transcript, and then turning that into clinical notes, so SOAP notes or something similar, a clinic letter. Some of the questions we have that we probably need to answer about, how we manage the risks or the benefits are, in general, these models tend to either make stuff up or forget to add stuff. So how do we manage that risk? one of the interesting questions is what's the consequence in conversation length and conversation quality? So we know there's a change in practice here. If you don't say stuff, it turns out that that doesn't get written down in the notes. So if you're going to talk more to the patient and you're going to turn it into more of a conversation, it's going to take longer, but presumably the quality of the conversation goes up. They feel more engaged and they feel like they're participating more. So pros and cons there. Is the time saving real? So in Te Whatuora, we did 75.5 million clinical interactions in the first quarter of this year. If we saved a minute from each of them, it's worth probably $50 million to us in productivity. So those are big numbers. Are they real? And then kind of what is different clinical settings? So Fred, you work in mental health. You know, does this tool work as well in mental health as it does in general practice? And does this work in outpatient clinics, or does this work in we've got one doctor that wants to have a stream of consciousness operation note while doing ERCPs. So does it work in that sort of context as well as it works in kind of some of the other contexts? That's kind of what we want to do in our product testing and evaluation to figure it out. Key point being, because we've built it, we're putting as much assurance as we can around the process. So in the right way, the data is being stored well, and we're not kind of trying to sell this to people overseas. So that's where we're at with those projects. Hopefully that's a good starter for 10 in terms of questions.
Yeah, perfect. Thanks, John. And I think before we go to you, Fred, there is just a question from Alex in the chat, and it has, or in the Q&A, sorry, and it's come up quite a few times recently in conversations I've been in. More specifically, we've started a bit of an AI in primary care rōpū that's kind of thinking about how we can leverage and use these tools to support general practice and other primary care providers. And one of the biggest challenges that we have is exactly what Alex said, is there's so much information coming into general practice's PMS. How do we know what's important? How do our doctors know what that important information is that they need to know to be able to do their jobs in a timely and an efficient way? So Alex's question was, access to data comes from remote monitoring, comes in from those devices. How do we ensure that it doesn't just add to that, I guess, pile of information that's coming in and the noise, and make sure that the important stuff is being brought to the attention of our clinicians?
Yeah, it's a couple of thoughts there. So first one is we don't even have a method to sort through what we think is good content. So as a health system, and I've interestingly enough, I've been on the eHealth forum this morning making this comment. Facebook, love them or hate them, pioneered the ability for you to like something. And so kind of the way in which it works is the more something people like, so a post or, you know, a comment or whatever, the more likely it is for everybody else to see it. Now, in the health system, all content is created equal. So you don't really have a choice about whether to read things or not. You kind of have to read them to know whether they're any good or not. So question, I think, and this might be quite limited in primary care to start, or in a hospital to start, but how can we signal the fact that we think this is a valuable piece of content? And it might be from our perspective, but I mean, if 10 people say, yes, this is a valuable piece of content, are you going to read that ahead of something that nobody has said is a valuable piece of content? So that ability for us as kind of people working in the health system to say, yes, you should look at this thing before you look at that thing, that to me is a really interesting opportunity for us to start looking at. The other thing, and I know Amy's working on this really hard, so I'm waiting for her to produce something that's really good, is the difference between process metrics and clinical outcomes. So we're being really careful in the project we've got to focus on process rather than necessarily clinical outcomes, because it's really easy for me to tell you that they didn't give us any data yesterday than to tell you that they're about to go to hospital. So where we're kind of starting is maybe not getting data is a good signal of someone not participating and therefore being more likely to go to hospital, but it's actually really hard for me to tell you that they were going to go to hospital. So from where we're kind of sitting, we think, hey, participation in process data might be a really good place to start with some of this, because if you don't have the data, you don't know. And so in that, you know, the people that sit at the top of the list where we're going to start is probably the people that aren't giving data. So you can intervene and make sure you're getting the data. Now, whether that data is good, bad, or indifferent is an interesting question, but come back to that other thought of at the moment, we currently don't sort it in any kind of meaningful way. And I don't mean filter it off, I mean sort it. We built a risk score in COVID, and really all that did was sort the cases that came through by likelihood of going to hospital. Didn't filter it at all, and there's significant risk in just doing that. So we had to do subgroup analyses for Māori patients, for poor patients, for patients with long-term conditions, in order to make sure that they're and they did, but you have to do that analysis and testing in order to understand that. So I think in the AI context, it's not as easy as turn it on and hope it works. There's definitely a lot of testing, and I think that's something that will be an ongoing requirement, I would suggest, of all of these tools, is particularly because they continue to change. You know, so someone said to me, "Oh, we've got this radiology tool we want to implement." And I said, okay, well, that's good. Does it work? Yes, it works. Well, what about the next version that they give you? Is that going to work? And they're like, oh, do we need to check that? I was like, well, how do you know if it's getting better or worse? So kind of this really interesting question in that context. So, Amy, I assume you've got a bunch of views on this too.
I don't think she was talking to us. I think she was talking to somebody else. But Amy, have you got any views to add into John's kōrero?
Sorry, as someone who's wanting my room booking, that's why. So apologies. But no, I'm aware of time, so I don't want to interrupt Fred's time, but we'll save it for the panel discussion.
Perfect. Cool. Thanks for that, John, and thanks for answering that question. I think it's a challenge we're absolutely faced with. And I saw Brendan Duck was on the call, and he wouldn't appreciate it unless I said, you know, pharmacy also have this issue, right? It's trying to get that important information. Coral and I met with a whole lot of pharmacists in the Hawke's Bay a few weeks ago, and one of the most compelling bits of information they shared with us was, you know, 1 in every 2 scripts that come across their desk is wrong. It's got the wrong medication on it. It's got the wrong dose on it. They're not sure about whether something's been stopped or started. There's just so much disconnect in information that flows. And that goes back to, is the information in the PMS really the right information for that GP, for that nurse prescriber, nurse practitioner to be able to make the decision making in regards to getting the right medicine for that patient. So yeah, big challenge for us in that space. But Fred, we're going to learn a little bit about you and what you're up to in the mental health space. So we'll hand to you to go through your quick slide deck.
Yeah, perfect. Thanks all. And really good discussion so far already. And I think it sets the scene up nicely because there's lots of overlap between what's been presented by Amy and John already and what I'm hoping to discuss. I had a little bit of a challenge actually compressing the PowerPoint down to reasonable size to email it across. So already challenged by technology at the first gate. So I think Ni is kindly sharing a PDF at her end, and I might need to prompt Ni with progressing the slides. So Ni, could you move on to the next one? Great. And just a couple of fine print and disclaimers for me. I work with a couple of organizations that deal with mental health, so Clearhead being one of them. And you might be familiar with Clearhead and their AI chatbot, and also have given advice to Lundbeck Australia with regards to a pharmaceutical agent for depression, currently receiving funding from industry, and that's with MindBio for work that we're doing with microdosing and LSD. And I'll talk a little bit about that in a second. Next, please. And I think if you could go back, Ni, a slide. Great. And I think we've covered this in quite a bit of detail already, how, you know, artificial intelligence is so prevalent. And if you look at a couple of these use case scenarios here, one on a personal level at the bottom with fitness tracking and looking at your metrics in terms of distance run, energy burnt, etc., etc. On the left, you might be on Facebook, and there might be also the analytics going on in the background you might not be aware of. At the top, in terms of sending emails to colleagues, ChatGPT might predict what you're hoping to type in next and helps you speed up that email. And to the right, with regards to healthcare specifically, things like radiology have got AI built in. So it's a rapidly evolving space with lots of integration with technology and AI in recent times. Next, please. So some possible descriptions or examples of wearables. The type of wearables I'm interested in particular are the smartwatches, but just to have a broader think about wearables, there's so many different types of wearables available. John has already mentioned oxygen saturation meters, continuous glucose monitoring meters. There's Google Glass to help you making medical decisions. I think rugby players and chronic traumatic encephalopathy, looking at the velocity in your shoes and your gait. There's so many devices out there that can actually give you lots of useful metrics. But the thing here is there's so much data and somebody's got to make sense of it. And whether you leave it to artificial intelligence or human intelligence, that's a delicate balance. Next, please. Yeah, so I'm guessing out of the audience here, we've got 36 people online connecting who are interested in this talk. Chances are you'll have one of these watches, on your wrist right now because you're interested in your own health and well-being. And as Amy mentioned, access to smartwatches is increasing. 1 in 3 people use smartwatches on a regular basis. And I think there's a line of thinking, the more that you monitor, the more that you're actually looking out for your well-being. But could also work the other way. The more you monitor, the more distress you could get by the monitoring that you're undertaking. So just something to be aware of. Next, please. So some of the benefits of wearables, they're getting a lot more sophisticated with lots more functionality being built in and lots more sensors being miniaturized. So you can actually compress a lot more sensors into your smartwatch, for example, for measuring oxygen saturations, potentially calories burned, step activity. You can measure sleep. And I think there's potential to measure blood pressure as well. I'm not quite sure how it does it, but John, you might be able to elaborate on some of the functionalities, but hell of a lot of functionality possible. The other great thing is you have 24-hour access to data or providing data. So it's continuous collection in terms of data gathering. Unless you are maybe charging your smartwatch or maybe having a shower, those are the only times maybe you might not be wearing a smartwatch. And accessibility, smartwatches are getting to be more affordable. So there's really basic models that you could afford to buy to really complex ones. And there's different sort of tiers and packages you could get from different companies with regards to your health analytics. Some of it is obviously with the intention of monetizing your data. But on a really basic level, you could get some good data even without any major subscriptions. Next, please. And this is sort of a typical pipeline in terms of getting hold of lots of data and potentially applying various forms of artificial intelligence, maybe deep neural networks, coming up with an algorithm that can make predictions about whether you're unwell, getting unwell, recovering. There's lots of different ways it can generate and report data. Next, please. So data from wearables, I think less so in the mental health space, being used for identification and diagnosis, but perhaps in other spaces with regards to physical health, let's say COPD, asthma, as Amy has mentioned. There's work in seizure detection, potentially using smartwatches, but also smart mattresses to actually detect movements when you're asleep. So potentially useful in a lot of different areas. And smartwatches or wearable data can be also used for informing management and monitoring, your well-being. So I alluded to funding from MindBio. This is one of the papers we published just a month ago. Looking at the healthy control group, we are currently recruiting people with depression. So in this healthy control group, what we actually found using Fitbits, and I think a relatively simple Fitbit model, I think it was a Fitbit Charge 3 or Fitbit Charge 4, that people, after they get LSD the very next day, when they go to sleep, they're sleeping earlier, and they get about 25 minutes extra sleep. And this was in a sample of around 80 people. And if you were to subjectively ask the person, how was your sleep? Did you sleep more? be very difficult for them to actually tell you what actually happened. So having objective data like this is really useful in terms of pharmaceutical trials and studies to get objective data. Next, please. Something that Amy and I work together on, and this is related to smartphones, is actually gathering voice data, because smartphones, like your smart watches, can gather a lot of data. For example, GPS activity, the number of phone calls, your SMS messages, ambient light. What we were interested in looking at was speech. And could speech be used to detect when somebody might be experiencing a depression? And the short answer is yes. And to a reasonable degree of accuracy. But if you think about it, probably fewer people are using smartphones to have conversations these days. Most people are probably texting and checking social media. So as an opportunity to detect depression, the opportunity is there, but you just have to think about how do we actually build in this as an opportunity to detect depression, and also thinking about privacy regulations if you're actually monitoring voice phone calls in real time. Next, please. So I just wanted to prompt reflection here with this next slide. The term mental is used a lot, in the media. And probably all these four terms will look pretty similar to the layperson, whether it's mental health, well-being, distress, or disorder, and often used interchangeably by lay people. And I think when people talk about their mental health, that's often interchangeable with mental well-being. So that's a very large space in terms of people not being clinically unwell. So they don't meet the threshold, but often thinking about when they're doing well and how to prevent themselves getting unwell. And mental distress tends to be a rather short-lived phenomenon, and often there are triggers to mental distress, and often self-limiting, self-resolving. And the ones I think many people in primary care and certainly in psychiatry are interested in is the diagnosis of mental disorder. And this is a lot more challenging, I think, using either smartwatches or smartphones. And I think there's some way left to go to be able to definitively diagnose somebody based on, let's say, heart rate variability or sleep data. But it can potentially provide a useful pattern of changes, for example, like your sleep. Next, please. The other thing to consider is measurement. What are we actually measuring? So historically, we've tended to use clinical face-to-face interviews in person, where we get the person reporting what their symptoms have been like the last X number of weeks. And this is often captured by the clinician. That's moved on to potentially rating scales, where you capture it with pen and paper. And you might be familiar with rating scales at the PHQ-9 and the GAD-7 for measuring depression and anxiety. And this has moved on as well in terms of technology delivery, potentially having apps that have this rating scales built in. Bearing in mind that these rating scales were not designed to be acquired through technological avenues, and they're not validated really, for technological avenues, but they are ways that can potentially measure subjectively the person's experience. Part of our line of research is thinking objectively, are there any potential biomarkers that might predict when somebody is depressed? And that's the current work that we are focusing on, looking at sleep, physiological markers like heart rate variability. And there's also other things you can get from your smartwatches, like your sleep architecture, sleep quantity, sleep staging, sleep quality, and activity levels. But the challenge here is mapping accurately what you can get from your smartwatches. You get lots of good data, but how do you map it to your classification systems or somebody actually being unwell? So we're not quite there in terms of matching or mapping exactly the smartphone or smartwatch data to symptoms. What are the other challenges with technology and AI? This is a term you might have come across, the black box, whereby the algorithms and the predictions are not clear to anyone, sometimes even to the organizations that have developed them, whether it's Google, Garmin's, Fitbits, whatever. So we are in the process of developing techniques that will help explain, and I'll talk about that in a second. There are potentially biases as well with technology that can be perpetuated by technology, and trying to disentangle the biases from the data that you actually need can be quite challenging sometimes. And part of the risk would be relying overly on technology as opposed to your clinical judgment and clinical acumen. So there's pros and cons of going deeply down the technology route. Privacy considerations, as John has mentioned already. And some of the predictions and clinical applicability, the considerations here are, we're not quite there yet in terms of prediction levels and accuracy. So if you were to take your heart rate variability and correlate it with depression, you might get a correlation of 60 to 70%. So it's not predictive, at a stage where we think, yes, this is clinically viable and appropriate. So recent work we published in the last year, looking at a data set of folks with depression, is to look at the weighting of symptoms and objective markers as to why a particular prediction model, an algorithm, might say somebody is depressed. Next, please. Yep. So these are some of the features and the weighting. So if somebody is anxious, if somebody is distracted, and this is a cognitive measure, and then what their diet has been like, if they're consuming lots of sugars or if they're not burning enough calories, you can actually get a hierarchy of features that contribute to the prediction of why somebody might is depressed. And this is considered an explainable approach. So the term you might also come across with artificial intelligence is XAI. So that's explainable artificial intelligence. And that's what we are working on. Next, please. So work like this is not going to be possible unless you have a multidisciplinary team. So we've got a team of fantastic clinicians, Amy included, and folks on computer engineering. And I'd like to emphasize a current study that we are undertaking called Mood AI. This is a study that we got funding from HRC to undertake research in people without depression, but also in people with mild to moderate depression. And you may have heard us presenting already where we're recruiting people with mild to moderate depression from primary care. Our research nurse, Claire, has been really busy working at networks in the university and primary care to recruit participants. But if you'd like to discuss more, happy to put up more information. It's available on the university website, social media, in terms of the referral criteria, but happy to talk more about it in a second. So thank you, folks. That's me.
Kia ora, Fred. Thank you for that, and thanks for sharing all of that rich information. I'm sure people would have been probably coming into this webinar thinking it was going to be wearables to take kind of heart rates and blood pressures and things like that. So it's great to be able to see the diversity in which these tools can go over. And I love that you can, I need someone to track my exercise intake and calorie intake too, and remind me about doing all of the things that I need to do. So I think, massive impact that can have on somebody. I'm going to run through a few of our questions that we've got pre-written for the panel, but do really encourage the people who have come along to the webinar today to put your questions in the chat for the panelists. It could be one that's just a general question, or it could be one specifically for one panelist. So do get typing away as I ask the kind of next set of questions. I guess leveraging off where you ended, Fred, tino rangatiratanga is one of our principles of Te Tiriti o Waitangi, and these wearables, what is the impact that that's having on somebody's ability to self-determine their health and to be able to take charge of their their well-being and bring that into their hands. John, I wondered if you had an answer to that partai.
I think that's what this is all actually about. So that there's a quote which says you spend more time on your phone in 24 hours than you would with any clinician in 3 years. And so in that kind of thought, you've got this question of, well, so what is it that helps people stay well? So come back to that comment I made, the health system's kind of designed around sickness rather than around wellness, and put that on its head, assume that someone has access to a phone, bit of an assumption there. Kind of where my head goes is there's probably 3 dimensions to this. Firstly, do I know what I need to do? So do I know what healthy eating is? Do I know that drinking too much alcohol is bad for me? Do I know that smoking is bad for me? Do I know that not taking my medication can be bad for me? So those are things I know The next thing kind of dimension that we think about is skills. So has someone taught me how to calorie count? Has someone shown me how to exercise safely? And then the thing that we stop at often on a regular basis, and I think we've had a look at a number of meta-analyses around kind of remote monitoring, and the bit that most people forget is this motivation bit. So there's a real difference between short-term monitoring and long-term monitoring, I think. So asking someone, and we saw this in COVID, asking someone to keep an eye on what their oxygen saturations when they're feeling terrible for a week, most people will handle it for a week. For 2 weeks, yeah, I'll give it my best shot. Hey, guess what? You've got a heart failure. I need you to tell us what your weight is every day for the rest of your life. It's a very different prospect, even if you know why you're doing it and you know how to measure your weight. Now, that's a really simple example, but there's lots of kind of evidence, and interestingly enough, this was a bit of a discovery exercise for us as well. A lot of evidence kind of coming out of the free-to-play games market around some of this stuff. So Candy Crush and lots of the Clash of Clans and apps online are kind of really interesting examples of where the term we use in data and digital is dark patterns are employed. So dark patterns are ones where you're trying to manipulate user behavior in order to be to buy more loot boxes or to buy the jewels in order to kind of go up a level. Now, those dark patterns are dark because they want to make you spend money which you didn't otherwise want to spend. But when you think about can we reward people for doing the right thing or having positive behavior? Hey, I didn't get a star. I did my symptom survey every day last week. We put a congratulations on the group chat. What might seem like relatively minor rewards actually turn out to be quite motivating for a lot of people. We did the work on COVID Tracer, and the number of people that have come up to me since when they realized that they could have a streak of, I think it was 7 days, and then have displayed on their phone just a kind of a swirly thing. Number of people that have come up and said that motivated them a lot in order to participate. For the view of a swirly thing and the ability to show someone else that they got the swirly thing, might surprise a lot of people about how much motivation is a part of this. And so, if you want to empower people, they have to be motivated in order to participate, as well as have the right education and as well as having the skills. So that to me is kind of something that we as a health system probably need to work really hard on, because it turns out we're the marketing department, and in most businesses it's the marketing department that cares about motivating that customer to buy their thing or to keep their gym membership when they don't need it. So hopefully that kind of gives a bit of context around where our thinking's at in terms of trying to give people ownership.
Yeah, and I think some of the extended care teams that we see coming into general practices are starting to support with that, right? And be, I guess, some of that sales pitch or the marketing team of being able to support with self-management. I know our health coaches are doing a really awesome job on educating and supporting and navigating self-management. So yeah, absolutely. I think that that's on the rise. When I talk to general practices about population stratification and understanding who is in their practice, we often talk about like 4 grids, and you can kind of picture the grids of being like you've got your worried well patients, and you've got your unworried unwell patients, and then you've got the complexities in between. Kim's asking around the unintended I guess, consequences of wearables, and maybe some of those kind of, worried start using their wearable, and is that going to then increase some of their anxiety, and is that going to then have, I guess, an unintended consequence on the health system in terms of them constantly, my blood pressure's up by 2 today, and I need to come in and be seen. What's your thinking about that? That's a general question to the panel, and how do we manage that?
I might jump in here briefly. I think there was an interesting example in the media last week. I think somebody in the UK, I think in their 30s, had atrial fibrillation, and their smartwatch picked it up and prompted her to actually seek help or get an ambulance, and she went to hospital, and it was a good outcome. And I guess that's the fantastic potential of the wearable, monitoring all the time and getting data all the time. But the flip side is, as you mentioned, if people are constantly being monitored and data is being fed to them about whether it's the lack of movement or blood pressure or whatever, there's a potential for self-diagnosis. And you've probably heard the term Dr. Google. You know, the more you read up on something, the more worried you get. So part of the challenge is actually having guidelines around the uses of wearables and smartphones in terms of how do you interpret the data, how do you make best use, when to approach your clinician. So people take it upon themselves to actually arm themselves with more knowledge by looking at Google for more information, but it does unfortunately raise anxiety, and having that conversation with a person preemptively before they get unwell and reassuring them could be useful, but doesn't work for everyone.
I think I'd add to that and say these people have these devices already and are already doing this. We're just blind to the data they're collecting. And so in some ways, you know, someone turns up and it might take quite a bit of a conversation to get to the point where you realize that, oh, the reason you're anxious is because you've been collecting this data. So I don't see that the data itself is the problem or the collecting the data itself. It's the come back to is that kind of skills, education, motivation question to go, well, why is it that you see this as an important thing to do? And it's really interesting. One of the things that we're thinking about is normative kind of ranges. So people will be familiar with, you know, normal blood pressure being 120 over 80, except the reality is nobody's blood pressure is 120 over 80. It's somewhere between, you know, 130 and 115 over 75 and 85 for a normal population. And so in that, you know, one of the interesting behaviors we could drive is, hey, guess what? Your blood pressure is the same as it was yesterday, which is the same as it was last week, and it's between the two, the upper and lower bound of what it normally is. But we don't have that data at the moment. Maybe the person does it, and maybe they don't. So you can start to see. I'm not sure it's the more data that's the problem. It's the interpretation of the data, and because we don't have it, we can't interpret it. So therefore, some of the stuff manifests a lot before it gets to us as a health system.
Yes, and I think I absolutely agree, John. I think it's just a different way of getting data, because before this, we're already opening things like patient portals. I think that's preceding. People already can see things like their own lab results and their own, you know, they already had traditional blood monitoring machines and blood pressure monitors, for example. So it's a different way of opening up data. And it's around managing and getting people to understand what that data means. And exactly as John says, that data is already out there. So it's around ensuring accuracy of the data. See, one of the comments is around data accuracy, but also it's allowing people to have access to the data. And by being upfront, I think about the data, since it's already being collected, what we're doing is facing the reality that this data is going to be there to stay. And what we're doing is acknowledging that because we have this data, can we make the most of it to improve health and actually help people have useful conversations about it?
Yeah, I think the accuracy thing's a really interesting comment. I think there's kind of this assumption that every measurement needs to be perfect. And I assume some of the people on the call have read some of the studies around the quality of blood pressure taking by health professionals, both the inter and interoperator kind of reliability of some of that measurement. And then if you apply kind of the patient variability to it as well, accuracy is a really interesting question. So, you know, that classic thing of assuming that you should prescribe blood pressure medication on the fact that you've just taken a blood pressure on someone who was late to the appointment, has the kids screaming in their ear, and hates you as a clinician, because they don't just hate you, they hate all medical professionals because they've had a bad experience. What's the chance that they're going to turn up with a low blood pressure? Do you see what I mean? Like, in that, you've kind of got this thought that accuracy is a really interesting kind of construct that we apply to some of what we do without really understanding the context in which we're capturing that data. So
yeah,
it's tricky. Tricky, we
the
don't have all the
beat.
answers. Funny that. Yeah.
So good. Hey, I am going to wrap us up because it's 1:30 and I know that you've all got other appointments and meetings and things to do today. There are a couple other questions in the chat, so if you do have a chance, jump in and give them a quick answer. The last one Daniel asked about was around Te Whatu Ora doing anything with Ministry of Education on education programs to support with, I guess, our health literacy and our education across our new generations coming into this space. I am going to close us out with karakia. Thank you so much for coming and being a part of this conversation. It's great to be able to think about what next and also think about how we can continue to support patients within primary care with long-term conditions. And it's a pleasure to learn from you today and to hear from all of the work that you're doing there out in the sector. So thank you. And I'm going to close us out with karakia. Kua wānanga mātou kia whakairia te tapu, kia wātea ai te ara, kia turiki whakataha ai, kia turiki whakataha ai, haumie hui kai ki.
Kia ora.
Kia ora, ka kite koutou.